Hi everyone, welcome back to Learn with MedNuggets. In this video, we are going to talk about supraventricular tachycardia. Supraventricular tachycardia refers to abnormally fast heart rate that occurs as a result of abnormal electrical activity above the ventricles, meaning from the atria. First, let's look into the normal conduction of the heart. In normal conduction of the heart, the electrical signals start in the sinoatrial node, which is located in between the superior vena cava and the right atrium. Then the electrical signals travel to the right and your left atrium, causing contraction of the atrias. After this, it travels through the AV node. The AV node delays the transmission of signals from the atria to the ventricles until the atria has fully loaded its blood to the ventricles. This delay is essential for the normal conduction of the heart. After the short delay at the AV node, the signals pass through the bundle of His to the ventricles, causing a ventricular conduction. In normal conduction, electrical signals pass only in one direction, that is, from the atria to the ventricles. But in supraventricular tachycardia, it is not as such. So there are three main types of supraventricular tachycardia. Atrioventricular nodal reentrant tachycardia. This is when the signals go back to the atria from the AV node. So the signals pass as usual from the atria to AV nodes to the ventricles, but then the signals pass back through the AV node back to the atria. The second type is atrioventricular reentrant tachycardia. Atrioventricular reentrant tachycardia is when there is an accessory pathway. So the signals pass back to the atria via a pathway between the atria and the ventricles. This is the most common type of supraventricular tachycardia. Having an accessory pathway is called Wolff-Parkinson-White syndrome. This extra electrical pathway will cause a slurred upstroke of the QRS complex, which is known as the delta wave, and a short PR interval in the ECG. These changes are seen because the electrical signals reach the ventricles faster without the delay at the AV node through the accessory pathway. The third type is atrial tachycardia. This is actually not a very common type of supraventricular tachycardia. Atrial tachycardia is when the electrical signals originate in the atria other than the sinoatrial node, causing an atrial rate of more than 100 beats per minute. Supraventricular tachycardias are mostly narrow complex tachycardias. That is, the duration of the QRS complex is less than 0.12 seconds. And in a normal ECG with a rate of 25 mm per second, the QRS complex will occupy less than 3 small squares in the ECG. There are 4 differentials to narrow complex tachycardia. First is sinus tachycardia. In sinus tachycardia, the P wave and the QRS complex are normal, but the RR interval is short. The treatment of sinus tachycardia involves treating the underlying cause, such as sepsis or pain, and also rate control with beta blockers if it's required. The second one is atrial fibrillation. Here you will see absent P waves and an irregular QRS complex. That is, the RR interval is irregular in the ECG of atrial fibrillation. The third is atrial flutter. In atrial flutter, the atrial rate is more than 250 beats per minute, and there is no flat baseline between the P waves, so you will see a sawtooth pattern. And QRS complexes occur at regular intervals depending on how often the signal passes from the atria to the ventricles. Usually, atrial flutter is associated with a 2:1 block. That is, you have 2 atrial contractions and 1 ventricular contraction. That is, 2 P waves and only 1 QRS complex. The other differential of narrow complex tachycardia is our topic in our video today. That is supraventricular tachycardia. In supraventricular tachycardia, the QRS complexes are regular. That is, the RR interval is regular, unlike in atrial fibrillation. Also, an important point that you should remember is that sometimes supraventricular tachycardia can have a broad QRS complex. This happens when there is a supraventricular tachycardia and a bundle branch block. So ventricular tachycardias, they also have a broad QRS complex. So to differentiate between ventricular tachycardias and supraventricular tachycardias with bundle branch block, these points will be helpful. Firstly, if possible, compare the QRS complex during tachycardia with the QRS complex in sinus rhythm. So if the patient has a bundle branch block in sinus rhythm, then the QRS complex during tachycardia will be same as when in sinus rhythm. Secondly, if the QRS complex is wider than 4 small squares, that is more than 160 milliseconds, the rhythm is most likely ventricular in origin. Thirdly, if there is any change in the axis compared with sinus rhythm, this also indicates a ventricular origin. And lastly, if the QRS complex is very irregular, the rhythm is probably atrial fibrillation with bundle branch block or atrial fibrillation with Wolff-Parkinson-White syndrome. Now let's move on to the management of patients with supraventricular tachycardia. Firstly, if the saturation of oxygen in the patient is less than 90%, then you have to give oxygen to this patient. And you also have to connect the patient to an ECG monitor to monitor the patient's ECG throughout. If the patient have adverse signs like shock, chest pain, ischemic features on the ECG, heart failure, or syncope, then you have to immediately do synchronized electrical cardioversion and give amiodarone to fix any electrolyte changes. In stable patients without adverse signs, firstly you have to check the rhythm. If the rhythm is irregular, then it is an atrial fibrillation and therefore should be managed as atrial fibrillation with rate control agents such as beta blockers, anticoagulation, and if needed, cardioversion. If the rhythm is regular, then this is a supraventricular tachycardia. So firstly, we do vagal maneuvers. Vagal maneuvers include a Valsalva maneuver and carotid sinus massage. Valsalva maneuvers can be done by asking the patient to blow hard against resistance. If vagal maneuvers fail, then intravenous adenosine is given, starting with a dose of 6 mg. And if there is no effect to 6 mg of adenosine, then we give 12 mg. If still no effect, then we give another 12 mg of adenosine. Contraindications to adenosine include asthma, COPD, heart failure, heart block, and severe hypertension. If these contraindications are present, then verapamil is used instead of adenosine. If after all these Valsalva maneuvers and adenosine, if still the sinus rhythm is not achieved, then the patient may need electrical cardioversion. Long-term management of patients with supraventricular tachycardia involves drugs like beta blockers, calcium channel blockers, amiodarone, and also radiofrequency ablation can be done. If you learned something from this video, support us by liking, commenting, and subscribing to our channel. Thank you.